Okay, thank you once again. I see I'm competing with the coffee break, but hopefully these cases will be interesting for those who are staying. So I'm going to show you a couple of my most difficult, challenging cases. And again, showing how if you use all the tools you have, you can sometimes overcome some very, very difficult situations. So my first is a young Russian computer programmer who presented with abdominal pain and weight loss, was found to have a 17-centimeter mass relatively centrally in his liver. Biopsy was read as a hepatic adenocarcinoma. I don't really know what that is. That's sort of a poorly differentiated tumor. Sounded bad. So we started in him with chemoembolization, and this is his first chemoembolization image. And you can see our catheter is in a very large right hepatic artery, feeding this very large hypervascular tumor. And we did Lipidol chemoembolization. And this was a non-contrast CT because I wasn't really sure if I got it all or not. And you can see, in fact, that I had not. That we have Lipidol uptake and retention in sort of the posterior portion of the tumor and some necrosis, but there clearly is an extensive anterior-inferior component of this tumor that has no chemoembolic emulsion in it. So we brought it back, and sure enough, there was a second right hepatic artery. You can see here, in addition to the left side, and we went out and selected that, and in the final picture, you can see this dense Lipidol retention through much of the tumor. And here's the MR following that. So you can see we have central necrosis fairly extensively through the tumor, but there's still the rind or the rim on the outside, much of it that's still viable. So the question is, what do you do now? Remember, he's only 34 years old. And we've probably, we could go back and do more chemoembolization, we could try TheraSphere, but he had a fairly decent-sized left lateral segment here, although the tumor did encroach fairly centrally. So I'm talking to my surgeon, he said, well, maybe if you hypertrophy the left lobe more, there'd be enough left lobe that we could just do a resection at this point. The tumor will shrink, the left lobe will grow. In fact, so raises one of the questions is, well, can you do chemoembolization and portal vein embolization on the same lobe? And in fact, you can. In fact, sometimes we do that on purpose. We have very bulky tumors, but what we're trying to do is downstage and assure an adequate future liver remnant. We'll actually deliberately plan to do that. So we'll usually chemoembolize first, give the tumor some time to infarct and start to shrink, and then bring them back and do the portal vein, maybe 2 weeks later, and do portal vein embolization on the same lobe. So now you've embolized both the artery and the vein to that lobe, which gives you pretty dramatic shrinkage of that lobe and stimulates the left lobe to grow. And then you give them about a month and try to resect. So that's what we did. We came in. You see we went contralateral. So I like to go contralaterally from the left side when I do my portal vein embolizations because it's very easy. You can stick the segment 3 portal vein under ultrasound very easily and get a catheter across to the right side. And then you can, usually what I do is I separately select the anterior and posterior divisions. I embolize with glue. It's very quick. The flow is away from you, so you can, you don't trap your catheter, and then you just come back. You can take the segment 4 branches if you need to, and then just pull out and embolize your track. So I like it because it's easy, it's fast, and the glue surgical oncologist tried to resect it, and he spent 3.5 hours dissecting the liver away, trying to free up segment 3 bile duct from the edge of the tumor, and he couldn't do it. So he just closed the patient and left him as he was because he couldn't get a clean resection margin and preserve the artery, the vein, and the duct to segment 3. So now what do we do? So I said, okay, well, maybe I can shrink the tumor more. So now I did TheraSpheres. So we did the same thing. He had the 2 separate major feeding arteries. So I did 2 separate Y90 injections. And you can see on the angiograms, there was still, hypervascular tumor mostly around the edge of what was left. So he got his 2 TheraSphere treatments. And now he had more tumor necrosis and more shrinkage of the tumor. But of course, the problem really is, again, you look at the cheese and not the hole. So if you look at the cheese, what you want to do, he now has this huge left lobe, all this hypertrophy, all this atrophy of his right lobe, but where the segment 3 comes into the hilum here, there's still viable tumor right along, you can see along the margin of the portal vein there, and here, right along the margin of resection, he still has viable tumor. So my surgeon still didn't think he could get this out with a clean margin. So how do you clean up the margin? So I went back in and I basically did a selective cryoablation, not of this whole huge tumor, but I basically placed multiple cryoprobes right along the intended surgical margin where there was still viable tumor left next to the portal vein and to segment 3, and basically froze that entire edge of the tumor. And then, after cryo, you can now see that this edge here looks pretty much dead. There's some reactive hyperemia around the margin, but now you don't see, you're still viable tumor on the rim peripherally, but next to the left lateral segment, now it looks like the tumor is pretty much dead. The other night, so not only did we kill it, but also with cryo, you get much more cytoreduction than you do with heat. So hopefully you'll get some more shrinkage away and get the tumor, that dead tumor to pull away. And then I very, very quietly took the patient and I sent him up to Memorial Sloan Kettering in New York and had one of their surgeons operate on him instead of my surgeon. Didn't tell anybody. And they operated for 6 hours, and they took out 7 1/2 segments. No, 6 1/2 segments. So they left him with less than 2 segments, 1 1/2 segments. Left him with segment 2 and half of segment 3, and a huge bile leak. And they left a drain in, and they sent him back to me to manage the bile leak. So I had to manage his bile leak for 8 months, but it closed. And he ended up cured at this point. So we ended up, this is segment 2 and half of segment 3, and eventually got all his drains out, and he was very, very, very happy. And so when his sister came from Russia, she brought me this very nice bottle of vodka from Legend of Kremlin Vodka as a gift, which was very nice. And then on his 1-year follow-up, he had no tumor, and he brought me a very nice bottle of French cognac. And on his 2-year follow-up, he had no tumor, and he bought me a very nice custom bottle of Patron with a fancy stopper, which I don't drink tequila, so I gave it to my son, who was very happy. And the best part of all is when they took out the entire tumor and they did the pathology on what was left, it turned out that it was actually neuroendocrine. So that's best news of all, because now he has a very good prognosis. If it's really an adenocarcinoma, you'd be very lucky if he didn't recur. So now we're out about 4.5 years, and he actually has some very, very tiny recurrences in residual left lobe. But, because it's a neuroendocrine tumor, he'll probably, I haven't treated them, I've just been watching them, because they'll probably go for many, many years. We put him on sandostatin, and that was it. So, a very difficult case, but it does show if you use multiple modalities and you're persistent and target your therapies, you can potentially take a very bad situation and turn it into at least a potentially curative situation, or at least one where he's probably going to get many, many years of life, and without any complications. So he was very fortunate. This one, not quite so good, but similar. So I specialize in 34-year-olds. This is a 34-year-old, but this is actually an Asian woman, mother of 2 beautiful young children. Again, had some abdominal fatigue, pain, and weight loss. They did a scan, and she had multiple liver masses, I think 8. Her AFP was over 450,000, and the biopsy was, they thought it was either hepatocellular carcinoma or a metastatic germ cell tumor. So they actually tried giving her the chemotherapy you do for germ cell tumor first, which did nothing, so we were sure it was a hepatoma. I actually don't have her initial scan because that was from the outside, but this was her first MRI at my place after I did her first chemoembolization. And you can see, so we have here a tumor in segment 6, necrotic, viable tumor here on the left, tumor in segment 4 that's now large necrotic, and then as we go down inferiorly, I've done the right lobe, necrotic tumor down here in segment 5, viable tumor here in 4, partial necrotic here, tumor in segment 3. So she really was a lot of holes in her cheese. So we brought it back and just chemoembolized her again and again and again. So this is her replaced right hepatic artery, feeding all these tumors on the right side. This was segment 4, feeding this huge tumor here in segment 4. Segments 2 and 3, you can see the lipidal retention. And this is sort of an X-ray with, at the end, just showing the, 1, 2, 3, 4, 5, 6, 7, 8, at least 8 and maybe 9 hepatomas that we had chemoembolized. So here we have our CT afterward. So on one hand, some of it's good. You can see she has excellent lipidal uptake and retention. And look how much the tumors have shrunk. So really pretty dramatic regression of her tumors compared to where we started here, here, down here. But this one out here in segment 2 is still growing and viable. So even though we thought we'd been there embolizing it, we didn't do a very good job. And also, notice here this one in segment 3, which is bulging out anteriorly. In fact, it's even though we have some lepiodal retention and necrosis here, it's growing, this component of it is getting bigger and actually kind of almost coming out through abdominal wall. So what do you think of when you see that? Right, systemic supply. So anytime you have a tumor on the surface of the liver and you chemolize the hepatic arteries, and the central portion takes lepiodol, but you have some component that's sort of exophytic and has no lepiodol retention, what that tells you is there's another blood vessel that's usually extrahepatic. So in an anterior location like this, it's going to be the internal mammary. Most common is the dome, inferior phrenic. Posteriorly, it could be intercostals or lumbars. Inferiorly on the right, it commonly proselytizes the epiploic branches, but this is a very common radiographic sign. And one of the nice things about using lepiodol is you see where your embolic went and where it didn't go. And so if you have a big deficit like this, this is a very good sign that you have extrahepatic supply. So here's her right internal mammary artery injection, but over the liver. And you can see here's the internal mammary coming down, here are the intercostal branches, here's superior epigastric branches, and here you can see this large anosculating collateral coming down, and then all this tumor stain. So we went down very, very selectively. The key is to get into this branch and get all the way out to the liver and get past all the chest wall branches if you're going to treat this. If you can't do that, if you can't get and isolate the liver supply, you can still treat them with bland embolization, but you want to not give yttrium or chemotherapy to chest wall supply. So we got down, and here we are after embolizing this, and you can see what we have left is just the normal branches, no more tumor blush. And then we went to the left internal mammary artery, same thing. So here's the left one coming down. Again, here are the intercostal branches. Here's that big, when you see this corkscrew, this anosculation, you know that's a collateral spiraling its way down into the liver. And again, we fished that out all the way to this branch, and here we are embolizing away and kind of pruning off all the tumor supply from this branch to the liver. So as I said, you have to be very careful because this is what you don't want to have happen. So these are not this patient, but a couple of patients who I treated where we thought we were being careful enough to do chemoembolization safely, but in fact, we got chemoembolic emulsion into the superior epigastric branches. So here's the guy afterward in the hospital, like within a day, and you can see he's got this geographic area of violaceous rash here. So this is a chemotherapy injury. They're extremely painful, and because the chemotherapy, it does what it's supposed to do. It kills cells, right? It binds to the DNA. So very painful, very slow to heal. This is that same patient at 1 month and his 1 month clinic visit. So you can see it's getting better. Fortunately, he did not get necrosis, and it's slowly healing up, and he eventually recovered from this. But this is another patient of mine who didn't. Same story, treating an internal mammary. She got this whole necrotic area of her anterior abdominal wall. We treated it locally for about 1 year, and it never healed. So I had to send her to a plastic surgeon who had to actually resect this and then close it up. So you can treat patients. Inferior phrenic is usually very safe because it's hard. You'll damage the diaphragm maybe, but patients tolerate that very well. But lumbars, intercostals, internal mammary, you have to be very careful. Epiploics, you have to be very careful not to get the colon or the bowel. So my advice is, if you're treating extrahepatic collaterals, unless you're 100% sure that you're only feeding liver, just do bland embolization. And the key is, if they have supply from the hepatic artery as well, embolize the extrahepatic vessels first. So go into the extrahepatic feeders, do bland embolization safely. That will force flow redistribution. Now all the blood supply to the tumor has to be coming from the hepatic artery, then go back to the hepatic artery and do your chemoembolization from there, knowing that anything you didn't get with your bland embolization from the outside will be fed from the hepatic artery. So here she is after doing that. And you can see, and we redid the left side as well for that left lateral segment. I'm not showing you that angiogram. So now we have excellent uptake and retention in that residual left lateral segment tumor here. Very happy about that. Here on the right side, this one bulging anterior thing in the front in segment 4 is still not completely filled in. So we were careful, but we clearly did not quite get the whole thing. So I was a little unhappy about that. That's the coronal view. Here's her axial view, and again, you can see that despite what we did, we still have a piece of tumor here and a piece of tumor here. This actually was fed by an epiploic branch. We eventually found that. So this was fed probably from the chest wall. This was fed by an epiploic branch. So we didn't quite get the whole thing. So now what do we do? All right, so one positive thing we discussed was ablation. Okay, so we didn't have that much left. Could we go in and just do an ablation for what's left? Now you have to be careful because the stomach's here. So you'd have to hydrodissect it away if you could, or use gas dissection. She was very skinny. So that would have been a challenge. Plus, the tumors are very exophytic. There's a lot of inflammatory reaction in the liver capsule with oily chemoembolization, so probably it would have been stuck. Maybe a surgeon could go in there, pull stuff away and do an ablation. Another possibility would be to do SBRT. All right, so more and more now, people are doing SBRT for these focal liver lesions. And the radiation therapists have gotten much better about coning down their treatment zones. But again, you have the problem of the bowel being right here. But the other thing you can observe now that we've had, notice how much shrinkage she's had on all these right lobe tumors over this period of time. So if you look at that, there's the level of the right hepatic vein. And if you look at that and go back to, let me see if I can go back one image, look at our coronal view, here's the posterior portion of the right lobe. That's the level of the right hepatic vein and the inferior accessory hepatic vein. Notice that the posterior segment of the right lobe is in fact tumor-free. So I once again, very quietly, shipped her up to New York, to Memorial Sloan Kettering, and they did an extended left trisegmentectomy and got all her tumor out. It took them 8 hours, to pick it up, because everything was stuck from the inflammation. It was stuck to the stomach. It was stuck to the mesentery. So they spent all day, but they in fact got what was at the time a curative resection, at least for that day. Now, unfortunately, she subsequently developed lung metastases. So we tried our best for this young woman and did eventually get her tumor-free for a period of time, but obviously she had hematologous metastases, which didn't appear until afterwards. So anyway, a couple very challenging cases, but shows that with some persistence and multidisciplinary care, sometimes you can get good outcomes. Thank you.
Last and not least, we'll call on Professor Ricky again and to be talking about liver metastasis.
Well, thank you. More of a little how not to, because I know that makes everybody feel better when you see what works, what doesn't. And I'm talking about radioembolization. No surprise, this is what I've been invited for. So I decided that I go in that area also for that presentation and tips and tricks. Now, what I would love to show is something that's largely underestimated in radioembolization, and we also heard the term SBRT from Michael, and also there's other techniques, radiation techniques of the liver, which is brachytherapy, for example, exposing various variable areas of the liver to radiation. And there is a disease, radiation-induced liver disease, that specifically in radioembolization, I believe, is largely underestimated. If you look at the publications on complications after radioembolization, the number that's coming up for something that might lead you to think it's chronic or it's acute liver failure or decompensation due to the radioembolization, the number is quite low. If you look at that data here from the Henry trial, hepatology 2011, grade 3, total bilirubin increase 5% and so forth. The data we have is retrospective, and I think it's not accurate. Radioembolization-induced liver disease is much more frequent than we all believe. And the first question, what is it? What is it? What is the nature of that disease? It's a sinusoidal congestion syndrome. It's roughly like a VOD, like a venous occlusive disease when you're doing a bone marrow transplantation, or oxaliplatin does do something very similar to it. What you see in these images here is that erythrocytes congest in the sinusoids, and the outflow, the venous outflow, is hampered. A little bit like in Budd-Chiari. That's why in the long term, something like a TIPS in that situation might be even a palliative approach. However, it's a clinical symptom. It's a clinical diagnosis. What you see is a weight gain, probably through the ascites, which is almost always present. Bilirubin is increased mostly, along with an intense increase of the AP, alkylic phosphatase, and moderate increase of the liver enzymes. Pain is quite frequent, and if you do the biopsy, you will see exactly what I showed you there, the sinusoidal congestion syndrome. And there is a 20%, it's been described by Bruno Sango in 2011, 20% chance if you do a total liver RE, the total liver volume treated in one session, your overall chance is 20% to reach something that is symptomatic. It might not kill your patient, but it is symptomatic for the patient. And normally in radioembolization, as we all know, it's palliative treatment, and what you don't want to do is bring your patient in trouble. Now, the risk factors, as described in that publication in Cancer here by Bruno Sango, the risk factors there were The low age, younger patients, for some reason, we don't know. Obviously, it's dose related. A lot of dose in a small liver will do more harm than lesser dose in a larger liver. The combination with previous chemotherapies, radiosensitizing for once, capecitabine, 5-FU, or Xeloda, that is something that does intense radiosensitization if you give it before and do the radioembolization afterwards, or if you do radioembolize and then you do your Xeloda. Unknown what the distance has to be, the interval. There is some radiosensitizing effect either way. What is not in that publication but seems to be very apparent is that if you have a strongly pre-treated patient, like with colorectal, with all the chemotherapy lines available, probably is more prone for a RILD as anybody else. Now, there is recommended medication also from the group from Pamplona. They tested cortisone. They had a cohort, they did treatments over years, and they do have a very precise, very detailed data collection there. And then they did a cut, and they changed the protocol, and they started with dexamethasone, as you can see here, the 20 milligram, to prevent RILD. And it truly, all of a sudden, when you read that publication, it shows that the rate of RILD incidences, it went down. However, question is, how precise is that? Because at the same time, they had also lowered the dose. So it's quite unclear if the effect is the cortisone or it's lowerage of the dose. Cortisone probably does something to the inflammatory response. Question is, does it prevent? We don't know. Now, split dose is something some centers, including our centers, do on a very regular basis on specifically risk patients. That means sequential lobar treatment, left and right side, at an interval of 4 to 6 weeks to allow one lobe to regenerate once it's been treated. And then when you do the other one, the one lobe that is regenerating will take over the function that's needed. Now, this is a publication here from 2011 from my own group on hepatotoxicity and what happens when you do the sequential lobar treatment as compared to total liver irradiation. And just a brief outcome, because it's a small patient group, we're talking about 40 patients here. It's not in liver toxicity grade 3 and 4. It's not significant here with that p-value, but you can clearly see when you look closely. This is bi-lobar treatment. That means total liver treatment, and this is sequential treatment. At 6 weeks, you don't see 3 to 4 toxicity in the sequential group, and you see a much lower toxicity after 3 months as compared to the bi-lobar, the total liver treatment. And it is significant if you go into bilirubin. The bilirubin increase after sequential lobar treatment at that interval of 4 to 6 weeks is much lower, significantly lower, than if you do total liver treatment. The same is true for ascites. I don't have the number here. You just have to believe me. Now, there is things coming up. We tested drugs that would prevent radiotoxicity. And we tested a combination, since it's a venous outflow syndrome, a combination of anticoagulation by enoxaparin, low-dose heparin, ursodesoxycholic acid, which is standard treatment, which, well, questionable what it does to the liver, but it's a standard medication in chronic liver disease, and pentoxifilene, it's also a rheologic agent, and we randomized against no treatment in patients undergoing focal liver irradiation. This is the doses, the dosing for the medication being taken, ursodesoxycholic acid at 750 milligrams per day, 3 times 400 for the pentoxifilene and enoxaparin injected subcutaneously, 40 milligrams daily. So we randomized against no treatment for focal liver irradiation. And this is quite interesting if you look at these images here. This is before focal liver irradiation of those 2 lesions here. This is Primovist, that means hepatobiliary contrast agent imaging, late phase imaging. What is bright takes up the gadoxetic acid, that's the Primovist, this hepatocyte selective contrast agent. And what doesn't take it up is exposed to radiation and has a focal radiation-induced liver disease. And if you look at that after 3 months, it regenerates. It starts to regenerate. This is a patient from the control group. The interesting thing now, in the treatment group, you can see the same story. After 6 weeks here of medication, there is absolutely no radiation-induced liver disease, no focal effect. It's a 100% straightforward effect, interestingly. After 3 months, you do see the effect, but the interesting news is we stopped medication after 8 weeks in that protocol. So you have a double check, more or less, in the preventive effect of that type of probably the anticoagulation is the key here. Now, to get to the case, how not to do it, that I promised to you. 56-year-old male colorectal cancer patient, total liver therapy, total liver radioembolization before we changed our protocol. Salvage patient with a lot of chemotherapy, weight gain, massive ascites, bilirubin 6 milligrams, so it goes up. AST, LT, the enzymes are moderately increased, but AP goes up dramatically, like in the like in the teaching books. What you see here is the edema of the legs, of the lower limb, which is not typical, and I'll show you why the edema is there. The typical thing, obviously, is liver decompensation. Ascites is a massive finding here, which does a lot of harm to that patient in the palliative situation, exactly what you don't want to have and don't want to do. Now it gets interesting. This is, the liver is like, it's ballooned, it's edematous due to that, like Budd-Chiari-like thing, venous outflow syndrome. There is obviously compression of the vena cava. You can see it here. This is where the vena cava goes up. This is the liver somewhere, and here's the heart, and you can see there's all collaterals and everything. And I just draw this. I've drawn the sketch to make sure that it's better understood what I mean. You did have a double concave compression there of the vena cava, leading to that edema in the lower limb. Now, a question to all of you, or maybe to the podium: what would you do, and specifically, what stent would you use? Any idea? Michael, what would you do with that patient?
So one question is, if you want to treat the liver first to see if it's better, put them on high dose steroids and see if that, from a short trial, see if it improves. Probably not. So then, I guess you think for the cavas, we usually use big wall stents, which are the most stable and less likely to migrate. So usually in this setting, we use large wall stents.
Well, next time I call you, the surprisingly conservative approach, nice to hear it, with the medication didn't work. We tried that, and the patient was just so symptomatic. We just thought, well, this is, you could see it on CT already, this is the problem. So we went in, and what I did, I remembered Cesare Gianturco, and you know what happened. Something to learn. I will never do it again, because what basically happened is, if you're not familiar with that stent design, here in the middle, there is no radial force. It's like two parts that are somewhat welded together. And what happened, and there's one thing, when that happens, you don't save all these pictures. So I don't have it, because when it happens, you don't think about publishing it, to be honest. So what happened basically was this here. You looked at your fluoroscopy, two of us, and I was watching around, and my fellow working with me said, "Oh no," and I'm like, "What's your problem?" And I look at the monitor, and with every heartbeat, you can see that the stent goes 1 centimeter, 1 centimeter, 1 centimeter, and start praying, but it doesn't help. So what happened basically, that double concave fitting of the liver, when you put the stent up too high, it's going to be pushed in the radial force, just not strong enough. It's pushed in the heart. Now, next thing, what do? Sorry? We did that afterwards, to be honest. The interesting question: who would do nothing? Anybody who wouldn't do anything? Because yeah, you'd probably, what we were afraid of, this is a tumor patient, his coagulopathy is very likely, and he's probably going to have an embolic problem if you don't do anything. So we decided to take it out with a gooseneck, because you're young, you're naive, you think it's no problem. So you go in with a gooseneck, again, no pictures, I apologize, because you just don't think about publishing this in that moment. So you put the gooseneck in, and you pull, and nothing happens.
Yes, yeah.
So what do? What I did was call my heart surgeon, just to get an opinion, and his opinion was, well, your atrium wall is thin like a leaf of an oak tree, don't pull, and he walks away. So, hasn't spoken to me ever since. So, Actually, to cut a long story short, I closed my eyes and I pulled, and I'm not sure if I should have done that. I'm not sure if I should advise anybody to do it. Well, very much fortunately, nothing happened, but we pulled it back into the cava, and we used balloons to nail it in the cava wall, and this is the picture afterwards. Looks a little strange, looks better than before. I wouldn't call it a success, to be honest, but symptom relief was there, so... However, that worked, not very elegant, but fortunately the patient didn't have any harm. So to summarize, not necessarily on the case, but on radiation-induced liver disease. There is one thing, when you read those publications or when you discuss it with colleagues or oncologists, if there is ascites or symptoms, liver function decompensation and ascites in a radioembolization patient after 6 weeks, it's not going to be tumor progression. I don't believe it. I think all these cases being reported are RILD, which has not been treated. Recommended treatment, there is, well, recommendation is probably not, it's too strong of a wording, but I showed you the data that is available. So symptomatic relief, for one thing, don't do it like we did it, but symptomatic relief. Specifically diuresis, because ascites is probably the dominant problem of these patients. To treat it directly, also desoxycholic acid, pentoxifylline, and enoxaparin, specifically also in risk patients, probably going to do a lot. Ever since we've been doing that, together with the sequential LOBA approach, we have not seen RILD anymore except for breast cancer patients. Young breast cancer patients, small tumors, small liver, are still very much at risk. Don't ask me why. Probably it's a dosimetric problem and maybe related to some drugs they get. I have no idea, but breast cancer patients are the ones that are still at risk. Well, thank you very much. I've shown that. If you're interested in courses, training courses, contact the Zotex booth, please.
Well, thank you very much, and I think that's the end of it. I mean, we wish you all a nice and evening, and we'll see you tomorrow morning. Thank you very much for the speakers, and thank you very much, everybody.